Today it has been released by Professor Des Gorman, Emeritus Professor Des Gorman from the Auckland University Medical School, and from Dr. Murray Horn, who I understand, I'm pretty sure I remember, was a former Secretary of the Treasury. Two men with serious intellectual grunt. A critical analysis of the COVID-19 pandemic management in New Zealand. It's been, if you want to go to it and read it fully, it's on the New Zealand Initiative. I'm looking at the full report of it now, and it comes up with 5 recommendations as to how you deal with the next one. The suggestion is that we're very much going to have one. Joining us to talk about the report and the political management of COVID over the last 3 years is one of the authors, Emeritus Professor Des Gorman. Welcome to the show, Des. Lovely to talk to you again.
Yeah, good morning, Michael.
As we know, there is is it a commission or a royal commission? I don't know. It is underway that's meant to report sometime in the middle of next year on pretty much how we managed COVID and the lessons learned going forward. You've sort of trumped them by about a year and 2 months with this one. What's your overall analysis of how COVID was handled over the last 3 years politically?
Look, 2 things. First of all, you're right, Murray Horn was Secretary of the Treasury. You're absolutely right. The second thing is, yes, there is a Royal Commission, and Murray and I elected not to submit to it because we thought the terms of reference were far too narrow, and we didn't actually think the composition of the commission was appropriate for its purpose. We thought it should be led by a judge or by a KC who was used to sort of separating the wheat from the chaff in terms of all the various proposals put to it. And also we thought that being headed up by a public health professor, and he's a very good one, by the way, but a public health professor indicated where they were going to head, whereas we thought the major impact of our poor governance and poor management was in fact social harm. So we don't think actually is an issue about public health. We agreed with the overall strategy and we agreed with the public health measures. What we're commenting is that they were very poorly executed.
All right. The point you've noted from day one is that New Zealand had a strategy of excluding the virus ever coming to here. So that was primary strategy number 1. And so we shut down. I think that you said very early on in the piece, forgive me if I'm wrong, this strategy won't work in terms of what you want to achieve, and its costs will be too high. Have I got that right? Because I seem to remember you saying that 3 years ago.
Yes, I did. At some stage you need to reopen, and if at that stage you haven't immunised everyone who you possibly can, and you don't have a health system that can cope with a surge in cases, then you're no better place than when you shut the door in the first place. And that all the expense and all the hardship will have been wasted. And that's one of the points we make in our report. In that August 21, when the Delta outbreak occurred, we had access to a vaccine since the beginning of the year, but only 20% of us were vaccinated. And the hospitals were no better equipped to deal with the surge than they were in February the year before. So you say, well, what was the outcome of all that hardship and all that suffering and all that social isolation? The answer is we were no better prepared in August 21 than we were in February 20.
Yes, remarkable. To whom would you suggest that blame might be attached for that? Is that a central government responsibility, or is that public health officials working within the Ministry of Health? Or is it just that it would have been impossible to do anyhow because we simply didn't have the health professionals or the management structure that could possibly have done it, even if you'd given them 5 years head start?
All of the above is the answer, Michael. Look, I feel very sorry for the public health people. When Murray Horn and I were at the National Health Board and running Health Workforce New Zealand, we knew that the public health system, the unit system, was completely underfunded and not able to accommodate even, you might remember they failed to address the measles outbreak, they failed to address the influenza outbreak, they failed to adequately deal with a water problem in Havelock North. So we knew before COVID that our public health system was completely under-resourced and unable to manage a complex event like this. But the real issue then became that we had politicians involved in day-to-day governance of the response, and that we left the actual operational response to the Ministry of Health, which, and again, it's no criticism of the people there, but they have no tactical experience whatsoever.
The fractured nature of the DHBs, God knows how many I've served on one actually for 3 terms, Des, so that must have contributed to this, because it seemed always like we had 20 silos all operating independently of each other, yeah?
Yeah, look, there's no doubt. Look, I thought the idea that Helen Clark had of district health boards with local representation and finding local solutions to local need made sense. In fact, it still makes sense. It just wasn't well operationalised. I mean, there wasn't a lot of interest in the public in voting for board members, and there was no coherent aggregation of those district health boards to behave collectively when they needed to. In fact, the way they were set up and the way they were funded, they behaved in the opposite direction. Look, you're right, the district health board system didn't help, but again, the problem here is that if you look at the vaccination program, the government decided to operate that using the Ministry of Health and district health boards. Well, neither of them have the intimate community knowledge that you need for a vaccination program. That should have been led by the GPs. That should have been led by the primary care providers. That should have been led by the local iwi groups who know who their vulnerable people are. And they should have been tasked with getting on identifying those vulnerable people and vaccinating them. The idea that a DHB or the Ministry of Health would know who the vulnerable people are and where they are is ridiculous.
You also make the comment in your report that the response on this matter was highly politicised. What do you mean by that?
Yeah. Well, look, with the irony here, Michael, is that we've got very good ways of managing complex entities or complex responses where the delineation between where politics needs to be and where it doesn't need to be are clearly identified. Now, obviously, if you're going to constrain people's freedom of movement and freedom of association, then politicians have to be involved in that constraint of movement and association. But in terms of day-to-day operating, that's not where you want politicians, and that's why we govern the ACC and the Reserve Bank and the Super Fund the way we do, where the Minister, as you well know, sets the mission, it establishes the reporting things, and can, if he or she wishes, dismiss the board. But day-to-day governance is with the board, and they are expert at governance. Now, the problem, and I mean no disrespect to your former profession, Michael, but the problems with politicians in day-to-day governance is, first of all, looking at the current government, how many would be appointable to the board of a complex company? Well, the answer is few, if any. But even if they were competent as a director, managing health and well-being risk on the one hand and economic and financial risk on the other is very, very difficult. When you then try to manage political risk as well, it becomes impossible. And that's the reason why we separate out the day-to-day governance of our complex organisations from the political management of them.
Yes, but the other thing that came out of that was that I was under the assumption, forgive me if I'm wrong, and I think this assumption's probably national, that the government was taking the advice almost in toto of public health officials and of Ministry of Health policymakers.
Yep.
Are you suggesting that was not the case, or it was the case?
No, that was the case. I think the problem was the politicisation of the response, and that inevitably leads to hubris and propaganda, unfortunately. But the politicisation of the response was made worse by then tasking the Ministry of Health with day-to-day management. Now, they're not a tactical organisation, they're an operational organisation, and they failed to do so. But where I think there was a major failure, and the point that Murray and I emphasised in the report, is that the public health advisors to the ministry and to the government, the ministry and the government, none of them took the human factor into account. I mean, this was a process designed for a species that doesn't exist, a inherently rational species rather than humans. And so I think the human factor was missing from the get-go, Michael. And one of the reasons why it's caused so much social division and antagonism and harm and ongoing suffering is because it lacked humanity.
Yeah, and you know, no question about that, and the resentment and the division of our society. But also, we're just talking now this morning, previously, Des, you coming on, about the cost educationally across the sectors as well, particularly with students. All right, now looking forward.
Oh, no, look, that's right, Michael. Sorry, just say that my grandsons, whose education was severely disrupted, now regard going to school as a discretionary exercise. The long-term impact on lost learning years, but more importantly, lost learning culture. I mean, goodness knows how long that will take to correct.
No, listen, God, I am actually worried about a generation of kids, Des, that will not be able to survive. And the other thing is that the really interesting thing is the gifting of credits during that period of time so that people could pass examinations. So you have to learn that stuff. They just gave you the credits so that you could jump over that particular hurdle. Amazing.
Well,
all right. Going forward, because, you know, lessons learned and stuff like that. If we have, first of all, just on COVID itself, you're expecting it to stay around forever?
Yes. I think it's going to become endemic, and you implied this in introduction, but we also fully expect there'll be future pandemics, and if we stag into them as unprepared as we were for this one, then shame on us.
We are staggering, aren't we? It seems to me that our public health system, of which you've taught within, you've taught the next generation of doctors, of specialists, our public health system is utterly reliant, it was when I was on the District Health Board, upon international migrants coming here and becoming nurses, clinicians and specialists. It's still dependent. It seems even more dependent, Des, now.
Yeah, well, you're absolutely right, Michael. In 2008, the World Health Organization came here. The guy's name was Pascal Zern, and he said our reliance on migration was unethical, unsustainable, and that we weren't particularly competitive. Now, he was exactly right on all three counts, and it's actually worse in 2023 than it was 15 years ago. I talked to the people who do the English language testing for would-be health migrants, and when they're asked what countries they're thinking of going to, let me tell you, New Zealand's not on the list. We're not even remotely competitive in terms of migrant health workers, and yet over 40% of our medical workforce is migrant. Our dependency on migration is it's unethical. We're a first world country. We should be exporting doctors to areas of need, not actually robbing countries of their precious resources.
Is it because the specialists that we do train, Des, I mean, whether after medical school, particularly specialists, leave anyhow? Have we got a massive leakage of people that we train?
Yeah, you're absolutely right. If you want to have a sort of a metaphor for our health system in terms of the workforce, consider a colander. And so we're pouring new people into that colander, both that domestically trained and imported, and they're just leaking out. And the question is, what do you need to do to stop the leak? And so, in my view, the first thing we need to do in our health system is not crank up recruitment. It's actually to deal with retention and extension of the people we currently have and look at why they are leaving. And they're leaving because of lack of flexibility, lack of autonomy. The patients are sicker and older and are struggling to provide the care they think they should be providing. But also, if you look at, I'll give an example of the point you're raising. Within 5 years of someone qualifying as a surgeon, 1/3 of them have left the country. About 1 in 4 of the doctors whose primary qualification was in New Zealand, about 1 in 3 of those whose primary qualification was offshore. Now, the immediate response is, oh, the greedy buggers are just off to a larger health economy to earn more money. That's actually, I think, unfair and untrue. What really is the issue is that we have no career planning. When you finish your surgical fellowship, if there happens to be a job available to you, then good luck. If there isn't, then bad luck. So the reason why a lot of them leave to larger jurisdictions is the chance of finding a suitable job. So here we are, a system that's entirely dependent upon the women and men that work in it, and we pay no attention whatsoever to their welfare, their health, their husbandry, their career planning, and so on. And I think back to my days in the Australian Navy, and the idea that we would have been that flippant with our resources would be unthinkable. So we have a laissez-faire attitude to the workforce and just assume that serendipity will hold the whole thing together. So the metaphor for our health workforce is a colander, and I think rather than looking at ways we can increase the flow into the colander, the smart play is going to be how do we plug these holes.
Professor Gorman, thank you very much for joining us again. As usual, you provide the most erudite of oversights, and your background on this is unparalleled.